Well, in exploring Accra, we also do know that it has a great connection to other scenes as well as sight and sound across the rest of the regions beyond Greater Accra. And talking about the whole country, we also do know that we are under restrictions, and this has been extended by the President in his latest address, as was broadcast live to Ghanaians, what the restrictions and the time period, the close of the month. But if you have any comment in relation to the President's speech, make sure that you touch base with us. We'll put our numbers, that's our WhatsApp platform and our Facebook, Twitter handle, as well as all relevant social media platforms right on your screens. In the meantime, we have to talk about many related factors because, you know, the comments or the announcement by the President and the content of his speech brought to home what needs to be done by the ordinary Ghanaian to make sure that we complement the efforts of states. And the wearing of face masks, as well as using hand sanitizers, and in the absence of that, making sure that we wash our hands consistently and running water with soap, have become even more paramount in these times. But look, let's go back to the President. Get an insert. We'll get on to stream, get onto the phone lines and speak to some significant persons, experts working on the front line on this pandemic.
Wednesday, 6th May, a total of 135,902 tests had been conducted, with our country's total number of confirmed cases standing at the time at 3,091, with 303 recoveries and, sadly, 18 deaths. On Thursday, 7th May, 14,046 more tests were conducted, and this included the clearing of the last set of backlogs. Our total confirmed cases then rose to 4,012 positives, i.e., 921 new cases. Our recovery stood at 323, 8 persons were critically ill, and death still at 18. It is important to stress that 533 out of the 921 new cases recorded between last Wednesday and Thursday are factory workers from a fish processing factory located in Tema. All 533 persons were infected by one person. Again, let me reiterate that these new 921 cases were from backlogs dating as far back as 26th April and not necessarily over a 24-hour window. The coming on stream of 7 more testing facilities across the country to complement the efforts of the Noguchi Research Institute, the Kumasi Center for Collaborative Research, and the National Public Health Reference Laboratory at the Kolebu Teaching Hospital have meant that we have been able to clear all the backlog of tests, and the reporting on the cases of infections since Friday, 8th May, is now current. On Friday, a total of 5,253 tests were conducted, with 251 positives. On Saturday, 2,255 tests were conducted, with 266 found to be positive. For today, Sunday, a total of 3,045 tests have been done, with 160 testing positive. These relatively lower daily numbers of infections are welcome and reinforces the fact that the measures instituted to help reduce person-to-person contact and help defeat the pandemic are working. So as of today, Sunday, 10th May, the country has conducted a total of 160,501 tests, with our total number of infections standing at 4,700, with 494 recoveries, 5 persons being critically ill, and 4,179 persons responding to treatment. 22 persons, virtually all of them with underlying illnesses such as hypertension, diabetes, and chronic liver disease, have unhappily died. We must understand that the more people we test for the virus, the more persons we will discover as positive, and thus have the opportunity to isolate and treat them. If you do not test people for the virus, you will not find the persons who are positive, let alone isolate them from the population and treat them and prevent them from spreading the virus.
And it brings to home what the related conversation should be, because all these content, as delivered in the president's speech, raise a lot of questions on the minds of many ordinary Ghanaians. But Mama V, we have more questions to ask.
Yes, we do. Fortunately, we have somebody who can help us answer some of the questions. We'll try and touch base with other experts, if you like, people with good knowledge on this subject. But let's start over the head of the ICU and member of the National Response Team, Dr. Chris Owu, who's at the UGMC, on the line. Hello, Doc, good morning to you. Thank you for your time.
Good morning, Mama V and Roland, and good morning to your audience. Thank you for having me again.
Yeah, thank you.
Great.
Thank you.
Good to see you. Hopefully you've had a very good weekend.
It's been a working weekend. As you can see, I'm not actually at UGMC yet, just preparing to go join my colleagues after a meeting with other members of the case management coordinating team. So it's been a working weekend.
All right, good. So for people like you on the front line, I guess an extension, as the president announced last night, will be welcome news.
Yes, it is. We know that there's been a lot of discussion as to what the president was going to say, and then what the implication of that is to patients that we're managing and people who may be infected in the communities and those who will be at risk. So yes, it is welcomed. I want to stress that we're all still getting to know a lot more, irrespective of what we already know about this virus and how it behaves, especially in the community. So any respite we get from increasing the number of people who are infected would be welcomed. There's still quite a lot of work to be done in the community, especially when majority of the people are asymptomatic or have no symptoms, to make sure that we break the spread of this virus here.
Yesterday, the president also announced a rise in the figures, the case counts, and indicated over 500 coming from a particular spot. As a member of the National Response Team, what can you tell us about that incident? And there are a lot of fears, honestly, because if one person can infect over 500, then we're not safe.
All right, so the pillar responsible in the COVID management for detection of people in the community is mainly actually with respect to surveillance. We work quite closely with them. And it is, yes, it is worrisome when you have a cluster like that happening. But that basically emphasizes what we've always said about this virus, that its ability to infect people is quite high. Yes, we know that majority of people who get infected may not have symptoms, but any one person who gets severe symptoms or dies is a significant one person. So it's so very easy to infect, and that's why we, as I said earlier on, it is a welcome respite while we contain fully this in our community. Basically, in factories, you know how the work goes. I don't want to believe that the factory didn't have any measures put in place to try to minimize spread between their workers. So it means that even in spite of some of those measures, the hand hygiene measures, the masking, that when you have people clustered together, very close by, working together, that the risk of infecting each other, if one person gets it, is high. Again, it also emphasizes the fact that we need to be continue to emphasize that the measures that we have mentioned, or the directive that the President and the Ministry of Health has put out there, are not for some times. They are for basically any time that you are exposed. So you can wash your hands 3 times a day, but that one time you touch a door handle or a doorknob without washing your hand could be the time you infected yourself or infected somebody. You could wear a mask, but if you keep pulling it down, if you keep touching the face of that mask and touching your face, or you keep letting it slide down, as we see a lot of people do sometimes, then you actually put yourself and other people at risk. So this, for me, is actually something that emphasizes that the directives need to be done, but not only done, but we need to also emphasize on doing them well. It's not, it's real. It's real. To have almost half the population of one factory affected by one or a couple of people is significant.
You know, when I was discussing this with Roland a bit earlier, he was talking about the contact tracing for the people that these people may have come into contact with. And he was looking at, typically for factory workers like that, the possible places they may be coming from. And I'm thinking that this may be even greater work for those who be doing the contacts.
It is true. It is a lot of work. And that's why I said it's been a working weekend, not only for those of us in case management, but all the other pillars of COVID-19 management, public health, surveillance, basically those who do the contact tracing, and then those who have to make the policy and make sure that these policies are implemented, monitored and evaluated. So it is a big job. Anytime you have one person infected, it means that depending on how long ago that person was infected, there are multiples or exponential number of people who could have come in contact, and therefore tracing them all backwards to try to get where they are. In situations of factory where maybe the people are working and living in the same community or housed together, that is a little bit easier, because if you can actually trace easily all the people that have been in contact, then you can actually isolate and treat and keep monitoring. But that is not the same for other scenarios where you have people coming from different places, using different modes of transportation, coming to work and going back to their families, going to visit friends, especially when we are not in a lockdown. Because then you have to actually depend on the person's ability to remember, as well as being able to locate real time those people that have come to contact with them. And as long as that takes longer, it means that the virus keeps getting spread or transmitted from one person to the other. And that is worrisome. So we're quite happy that the ban on gathering, the closure of the ports, airport, land ports, our borders is extended for a little bit more time to give us opportunity to contain this. Because if you take with respect other modes of gathering, that is a lot more difficult to trace back. There are loads of people coming to church from different places. If you have to trace back from a church, that obviously would be a lot more difficult, if you get what I'm trying to say. Yeah.
And I'm here, Chris. So I'll take the next 2 rounds of questions. And I'm looking at the case count for the regions. Greater Accra in excess of over 3,000. Where are they? Where are they in Greater Accra? Or let's say in Accra and Tema. Where are they?
Yeah, I mean, when you have community spread, you will have cases in a community. The idea is to as much as possible, I identify the people who are positive and then isolate them, and which is what we are quite aggressively doing at the moment as part of case management. But it means that depending on how soon those results came, that sometimes even after you have identified those who are positive and moved them, that you still have a lot more people to identify, test, and treat. Now, that was part of the reason why we probably had a bit of delay in our earlier labs when we had enhanced testing because of the glut of numbers that was coming to the labs with its capacity at that point. So it meant that their capacity was a bit stretched. We're happy that the capacities have been significantly increased and other labs have been brought on board to reduce the delay happening. Because if I pick a person who is positive by testing today, I can't say that that person got infected today. I can't, if I did a test today and get the result in 1 week and it is positive, the person would have had opportunity to infect other people in that 1 week before I even identify and then isolate that person. So laboratory diagnostics is an extremely important pillar in all this, making sure that we get a timeless result so that we can identify and isolate. Again, stigma in the community is playing a very bad role in all this, because if people are afraid of being stigmatized, then even when we know that they are positive, sometimes it can be difficult identifying them. We know that there are people who have switched off the phone, there are people who have been called, and then when they get there, there's been sometimes resistance in the community. Again, there are people who still do not believe that this virus is real and that the lab test is helpful in identifying and controlling this. So yes, we have a good number of them in treatment centers. Those that you already know of, East Municipal Hospital, University of Ghana Medical Center, the teaching hospital, the Greater Accra Regional Hospital, Tema, for Greater Accra, and then a few in other places of isolation and facilities. Thankfully, we had the coming on stream of the Pentecost Convention Center, where we have isolated a good number of those who are not with symptoms while we observe and then treat or translocate them if can necessary. But yes, there is still quite a good number that are in the community that are still being identified and then isolated. And that is the way to go. It is not an easy task. It's not an easy task by any stretch. Our address system has not always been easy to identify and pick people up. But the national security, other security agencies have been extremely helpful in helping us identify these people and move them to places where they can be isolated, retested, and treated here.
So it means that we have nobody who has tested positive and is at home.
There are people in the community. I mean, it's an ongoing activity. When you pick up a number, the numbers that we're picking, they are in scattered places. You can't get them all out in a day. It takes some work. It's a bit different from those who are from a factory, where almost all of them are identifiable easily, where they can all be moved, or those from one institution, be it health institution or any other institution. But when you have a community spread, the work of even going to identify whether the person is still residing where he was when the test was done can be quite tedious. And that is why it is important that we have some respite in containing the spread. Yes, there will definitely still be people in the community, in their homes. There will be people who have moved to other places because of stigma and the fact that they've been told that they're positive. There are a lot of education, and I'm happy with the information on NCCE, assisting NCCE to scale up the education in the community. There are other groups, both governmental and non-governmental, that are trying to do a lot of work on the psychosocial aspect and trying to bring down the stigma, because you can get people who you can identify where they are, but if people are making conscious effort not to be identified, it is a lot more difficult to do to get them to isolate them.
I was trying to ask, those that we've identified and tested positive, are any of them in the communities? That's what I'm asking.
Yeah, so yeah, Roland, that's what I'm saying, that there definitely are people in the community, because they're not because we decided to leave them in the community. We have a policy of basically not doing home care at the moment. So if the question is, are we caring for people at home after they've tested positive, that is not our policy at the moment. We are identifying, isolating, monitoring, and treating those people. Now, you can only isolate somebody that you've gotten hold of. So yes, there are people who are still resistant in the community from being identified. There are people in communities where there's been a bit of difficulty getting through. There are other communities that have been fantastic in helping where they are community leaders, and that is where the role of community leaders, traditional leaders, is extremely important. A number of communities, they are opinion leaders, they are traditional leaders, they are political leaders, have been helpful in educating their people and then helping to make sure that people understand the need to isolate and monitor and retest and treat these people. And in those communities, we are making a very good headway. But as I said earlier on, Roland, this does not happen in a day or in a week, especially when, as I said again earlier on, the virus keeps spreading until you are contained. But there's a lot of work going into containing the virus in our communities, yes.
We've heard how all the people, Dr. Owo, all the persons who have unfortunately died have had some underlying issues. Are we still on that same, tangent, if you like? Have all died because basically they've had some underlying issues?
All right. So thank you, Mama V. Yes, we've always known that there are factors that contribute to how severe your illness will be. Yes, there is also, again, a lot we still do not know about this virus, but we know quite a lot about how it behaves, what it does to your body, what it makes your body do to itself by fighting itself, by in attempt to fight the virus. Now, those chronic conditions like diabetes, hypertension, asthma, heart disease are strongly related to not just severity, but also the risk of dying from the virus. But it does not mean that that is the only reason people will die. There are people who may not have comorbid condition, but who may, nutritional-wise, immune system-wise, have been suppressed, or who, for example, somebody who has not been well recently. Our body defense mechanism works in a way that it tries to defend us against any invaders. Now, to be able to do that, your own immune system needs to also be up to the task, even if you do not have those chronic conditions. Because what those chronic conditions do actually is try to reduce your ability to defend yourself. But people of older age, significantly people above the age of 60, 65, I mean, in other places we talk about people above the age of 70, people who have diabetes, because these are things that reduce your immune system, people who have hypertension, people who have sickle cell, they have an excess risk, or what we call an extra risk factor.
So basically in Ghana, basically in Ghana, all the persons who have died have had some issues already. Is it because the virus was detected a bit late, so that even if I have an underlying condition, I have diabetes, for instance, but I detect, or it is detected that I have COVID-19 early, my rate of survival will be high?
All right. Thank you again. Again, let me just say that there are people who have died even before we realized that they were positive, because they were very ill when they came to hospitals. Some of them, by the time we detected, part of the reason that the test was done is because they were so severely ill. And for us, people who are severely ill, for which we cannot find a good reason why they are that ill, we recommend testing for COVID-19 virus. Now, some of them, by the time the result came, because they were really ill, were already dead. Now, for those who ended up in ICU and who died in ICU, yes, all of them had other condition risk factors that contributed to that. But not all of them were old. We've had people who were a bit younger, in their 50s and in their 40s. So, and again, some of them who were severely ill in ICU, who have survived and gone home, did not even know that they had some of those medical conditions. So diabetes in Ghana, hypertension in Ghana is quite common. It's not rare. And it's not only the elderly who have diabetes, hypertension. There are people who have been diagnosed with diabetes and hypertension because during this, so it's difficult to even say, oh, okay, because you have that, you should stay far away from the patient, from everybody. Yeah, so it's a bit difficult, but yes, those who have that. But then again, let me say that part of the reason people were also presenting late is the stigma. There are people who have found out that they have symptoms, and because they know that these symptoms are similar to the symptoms of COVID-19, they have stayed at home, hopeful that they will be among the majority that we say that may not die from it, and then do not tell anybody because they don't want to be stigmatized.
So is it stigma from, Doc, sorry, is it stigma from their immediate environment, or stigma from the hospital or the people who come and take the samples?
There's a lot of stigma in our community, and I think everybody has been talking about that recently, a way of dealing with it. People, we have as well. I mean, people have fears. And there's nothing wrong with being scared. There's nothing wrong with being afraid. But being afraid means that you are cautious. You are careful with what you do. But sometimes fear translates negatively to stigma, where people do not only not want to be associated with these people, but also the way that we talk about it, the way we relate to them, even after people have recovered. Community rejection of people who are fully recovered. Okay, Dr.
Owo, can I bring something to your attention? Because we're talking about stigma. I've heard some people say when they call and you're part of the national response team, the way the vehicle, the ambulance will come with a siren, I mean, everybody in the community would immediately know that there's something happening. Is there a way that we can manage it, any differently from the way we've been doing it?
Thank you again. I think a lot has gone into that recently. There are a lot more discreetness as to how people are picked up by the national security. There is a lot more discreetness as to how people are returned back to their communities. It's a balancing act. It's a balancing act, especially when there are difficulties in getting access to communities. You have to be identifiable. I mean, you can't just walk into somebody's house and say that I am this so person, and therefore come with me because I'm going to send you to isolation, and the person will agree. So people have to be able to identify who they are and the authority that they have to execute their responsibilities. Yes, when that is exaggerated, it can actually create panic, it can create fear, and we are aware of that. And that, therefore, there is a lot of balancing. Again, when you're returning people back to their homes when they have recovered, there are instances where people halfway do not want to go back to their homes. and therefore you need to be careful that you do not also leave people halfway. So it has to be.
Is there an alternative if somebody doesn't? Is there an alternative if somebody doesn't immediately want to go back to their homes?
We've had people who have said to us when they have recovered that I am not too sure I want to go back home because of what I've heard from others that have gone back home with respect to stigma. What we have is we're working a lot with the clinical psychologists and psychiatrists. We're working with their national association and their bodies. And then, of course, this non-governmental bodies and other institutions that work on this. Because,
so you must go home when you recover.
We can't keep them forever. We need that space to also be able to isolate other people. So again, it comes back to the balance. If you send them and they are rejected from their community, it may mean that we have to go pick them up and then house them. But remember that they have recovered, and you don't want to keep them exposed, continue to be exposed to the virus.
I've got a last question for you, Dr. Wu. Sorry. Yeah. How many doctors, nurses, first responders have been infected with COVID-19?
And how many of them have you tested?
All right. So first of all, I don't have the answer to both questions because yes, we coordinate what happens nationally, and then we try to get information. So that information is actually continuously being put together. But yes, the job we do is a high-risk job. We understand that. We signed up for that job. We try to protect ourselves. That is why you keep hearing us talking about PPEs, personal protective equipment. So we do not. It is not that we do not know that irrespective of what we do, that there will be health professionals that may get infected. We understand that. What we try to do is, as much as possible, reduce that to the minimum and make sure that anybody who does get infected is treated. We have measures that we put in place in our treatment center and certainly in basically all health institutions to try to also look at how do we pick early health professionals who get infected. But because, again, we work together. So if one person gets infected, it's at risk of infecting other people. So in a number of the our health facilities, people will check their temperature, or somebody checks your temperature when you come in and log that in, and when you go out, and somebody records any symptoms that you have. So there is a questionnaire to find out whether you have any symptoms, and we keep re-educating even ourselves that it is important, it is to our interest, it is to our family's interest and our colleagues' interest to report any symptoms that we show at any point in time. It may mean that we quarantine you for a period of 2 weeks, and we will test you if you have symptoms, and at the end of that 2 weeks, before you go back to work with others. So no, we don't just have a blanket recommendation to test every health worker. Again, that will create a glut in the laboratory systems and affect what we do. But we are quite aggressive in isolating or quarantining and testing health workers that show signs of symptoms or who have been in significant contact without appropriate protection with those who have been found to be positive.
Okay. So I have a senior medical nurse who had a positive patient in her accident emergency ward. Now, she has not been tested, and she will go home, and the family will still be in doubt whether she's okay, because she and her colleagues in that ward had been nursing that person for the last 5 days. Because when the first sample was taken of that patient for that test, it had to take about 5, 6, 7 days for the result to come. At that time, they in shift were treating the patient, and the patient
not knowing
and the patient hadn't come into contact directly or traveled, etc., but had come into contact with her grandchildren, her children, etc., in a house, in a congested community.
Yeah. Okay. So Roland, thank you. It's difficult to speak to isolated incidents that especially if we're not aware of them. But yes, there have been incidents where patients have been found to be positive after people have nursed them for a period of time. And therefore, those people become contacts. We've had significantly a number of our facilities, health facilities, which where portions have been closed down while staff have been quarantined. I'm sure you that of a couple of the hospitals in Accra recently. And this is because we have a rapid response team in every facility, in every district, in every municipality, in every region. And there are means of reporting incidents and people respond to them. Now, it is difficult if the incident is not appropriately reported to act all the way from national. So, for example, Greater Accra Regional Directorate, Health Directorate, would have the handle of mostly what happens in Greater Accra, although we work collaboratively with them, and other regions the same. Now, again, let me say that the fact that a patient is picked positive does not mean that we necessarily have to test everybody immediately. And there's a reason for that, and that is the science of all this discussion about the virus.
Not even the doctors and the nurses, the nurse is taking care of this person?
Yes. So that's what I'm just explaining, the science behind all this.
Okay.
Now, if I am nursing a patient who is COVID positive, let's say I started nursing a patient yesterday or today, and then I find out that the patient is positive, and you go and test me. Now, I most probably will be negative because you've not given me enough time to actually have that virus incubate itself in me and be transmissible.
That's even more dangerous.
No, so if you test me immediately, then it may be negative. So that is why the decision is usual to quarantine those group of health workers. So you would have heard, again, in all the ones that have been reported, that they were quarantined. They were kept away from their family.
Okay, Dr. Owo, not to cut you, I'm just following the explanation. So I've got a quick question there. So immediately you won't test me, but can I pass it on? Can I get somebody infected? Can I reinfect?
You may be able to get somebody infected, but if you have had it on for, let's say, a number of days, long enough for it to incubate and be able to transmit. So that is why you want to keep that person away from others, and that's the quarantine.
Okay, again, so it incubates before it transmits, is that it?
Yeah, so the virus gets into you, immediately it gets into you. If somebody unfortunately coughs to your face who is positive for COVID right now, and coughs into your face, and you think that you've been exposed because you're not wearing a mask, and therefore you go to test right now, you'll be negative. You'll be negative because it has not had enough time to get into your system and come out through the...
Okay. Wait.
Roland, wait.
The person got exposed and then coughed in the face of somebody. The person just got exposed and coughed in the face of somebody. In real time.
I was actually going to, Roland, hang on. I was, Dr. Owo, hopefully your connection is stable. I was going to use that same scenario. So the person coughed into me, but I test negative. But if I coughed into Roland directly, would I be infecting him?
Immediately.
No, you will not be. Okay. You will not be infecting Roland, okay? Because you haven't even been, you don't even have COVID at that point in time, in quotes. But then it does not mean that you will not eventually have COVID, because it will now pass through your system, it will get into your bloodstream, it will come out through your respiratory secretions, and that's when you are able to infect other people. Now, during that period of time, you may show symptoms, you may not show symptoms. If you do not show symptoms and we allow you to go back to your family, what that may do is basically that you're not showing symptoms, but you're able to transmit to other people and you contaminate them. But if we quarantine you and you start showing symptoms, we will test you. If you do not show symptoms, after a period of time, usually 2 weeks, because we know that the average length of time...
But Doc, what if that person is asymptomatic?
Yes, exactly what I mean by not showing symptoms.
Yes, but
So
you're not testing.
Yes, so we're not testing you if you do not show symptoms, but we will test you before we release you back.
Okay.
And by that time, we would have given you enough time to have the virus go through your system per our protocols. So anybody who is quarantined, any health worker that is quarantined, at terminal quarantine, the terminal part of your quarantine, you will be tested. You will only go back to work or go back to your community and family if you're negative, meaning that you did not, although you were exposed, you did not contract the virus.
Are you testing for negative twice in this instance?
If you were negative on your first test.
No, because you haven't even tested this person.
So
you only isolated.
No, so we are not testing for negative twice in such a situation because we're not talking about recovery. We are trying to determine whether you are infected or not.
Okay.
So after that 2 weeks, you're just going to be tested once. You'll be quarantined. So if you were positive, you would have shown it. So we will not test you twice. That would be once.
Okay, I have a last question. Mama V says you're exhausted, so we should let you go. The president in his speech, and this got even medical doctors on my old school page arguing because it's logic. He says that we're getting more cases because we're doing more testing. So it means that we'll get more cases. And going by the numbers that he reiterated were the positives that were recorded since the last case count before his address, it means that we're likely continuously going to get more cases as we do more tests.
All right, so Roland, if you have community spread, and community spread means that there will still, even when we say that we have significantly gotten out of this, there will still be a few people who will still be passing it on until totally it disappears. Now, when you have community spread, the more you test, the more you detect those who are infected. If we decide to not test anybody in Ghana today, we will not pick a single positive. It does not mean that there are nobody who is infected. So yes, if you have a very vigorous, aggressive mode of testing, a lot of people, the more you test, the more you pick those who are infected. But those are people who are infected. It's not like it is the test that is transmitting to infection, if you get what I mean. The less you test, if you have a lot of people infected in the community, you will not pick them up. So it is important to test. It is important because if you can test, then you can pick those who are infected. You can isolate them, you can monitor them, you can treat those who require to be treated. Okay, so yes, it is true that the more you test, the more you will detect if there are. Of course, irrespective of how much we test, eventually, if we have eventually totally contained this infection, and there are not people who are spreading it because we have moved or isolated those who are positive, we would start seeing very tiny numbers or nobody infected, nobody positive, purely because the infection is not in the community at that point in time.
All right.
But then the only way we can tell is by testing, but with testing, we need to be aggressively isolating and monitoring and treating. And that means that we need to have cooperation in the community. We need to have people understanding that it is necessary to contain this. We need to have people following the directives that have been put out there. Yeah.
All right. Dr. Chris Owo, we thank you for your time, but how many people do you have in your ICU in terms of patients?
So I can, this morning I can speak to basically the two ICUs that I'm directly looking after. There are about 3 of them there now, but I can't give you fully national because we would get that later. All
right. Thank you for your time. We thank you really for your time, and we wish you the best even as you set off to go to work. Thanks to you and your team. That's head of the ICU and member of the National Response Team with the UGMC, severe and critical cases. So there you have it. That's the updates that we have. Hopefully we've asked all the questions on your mind as well. We've got another conversation coming your way right here on the show. Stay with us all through. and send us your comments.